everyone, and thank you for joining us tonight for what promises to be a very interesting and informative webinar. I'm Fazila Rupani, I'm Head of Clinical here at DD, and I have the pleasure of introducing tonight's expert speaker who will be delivering the webinar for us. Now, the topic of minimally invasive dentistry is an interesting one, and we all know that it's highly relevant to us right now as well, especially given the various guidance documents that have been issued in recent months during the pandemic, for example, from the English CDO, as well as others. And they're all advising us on how we can reduce the number of aerosol generating procedures that we're carrying out by using various alternative methods when carrying out our dental procedures, including using minimally invasive techniques. However, MI dentistry actually dates back to the 1970s, and the philosophy has formed the foundation of dental training for many years. I was certainly taught it as an undergraduate, and now as a cons clinical teacher myself to undergraduates, I certainly push the concept to my students when I'm teaching. However, I find it quite interesting that whilst many of us are taught about the concept in dental school, once we get out there into the real world, we sometimes forget its relevance. There are many factors that may influence this. For example, we know that it's quicker sometimes to use a burr to remove caries rather than hand excavating. Or sometimes we may be striving to place a more aesthetically pleasing crown, which requires more tooth removal than is strictly necessary. There are a whole host of reasons that we could debate. However, ultimately, we all know that there is great value in trying to preserve as much natural tooth tissue as possible, whether we are in the middle of a pandemic trying to reduce AGPs or not. So in tonight's webinar, we will aim to refresh the concepts of minimally invasive dentistry and focus on how chemo-mechanical caries removal using the unique product Carisolv can be a real asset to your armamentarium now and even beyond the pandemic. Our expert speaker, Dr. Stefan Edgren, will explore this important topic in tonight's webinar. Stefan graduated from the University of Gothenburg in 1979 and has enjoyed a long clinical career in general practice with a special interest in implants, alongside a commercial career where he has held several senior advisory roles for key market players, including Nobel Biocare, Biora AB, and more recently, RLS Global, who manufacture Carisolv. Stefan has a long-standing interest in minimally invasive procedures, and DD are delighted that he can join us from Sweden this evening. His presentation will last around 45 to 50 minutes, and this will be followed by a live Q&A session. So please feel free to type your questions into the question and answer box, and I'll be collating them and will present them to Stefan in the Q&A session. So without further ado, I will hand over to Dr. Stefan Edgren. Thank you.
Well, thank you, Fazila, for that kind introduction. I hope you would not mention that I graduated as early as 1979, but as a fact, I've been around for quite some time, and I always had a keen interest in minimal invasive procedures. So I will just try then and start talking about Carisolv. Carisolv is a gentle and safe caries treatment, and it's been an important part of minimal invasive procedures as far as I'm concerned. What you see here is some statistics that actually is derived from the Swedish authorities, which is similar to the NHS in the UK. This represents the patients treated in various age categories over a period of 1 year's time. And what you can see here, of course, is that caries, which is represented by the red field, starts
Sorry,
to develop.
we just think your slides. Sorry to interrupt.
Sorry, yes,
Are you sharing your slides?
I am.
There we go. We can see it now.
Is that better?
That's better. Thank you.
Okay, thanks. Sorry about that. Not quite used to this sort of technical things around this presentation. I hope it will work now. So what I was about to tell you was that this slide indicating the statistics from 1 year's production in a dental general practice in Sweden. And what I was about to say was that the red field represents procedures that has been initiated by the fact that there's a caries decay in the patient. And the green field is represented by the procedures that actually is initiated by fractures of cusps and fillings. So what we can see is that there is a slight increase of the caries in the years between 25 and 35. And then it stays fairly straightforward and stable at about 20% throughout the various years. But what happens, which is perhaps more interesting to me, is to see that the green field, which then represents the fillings and cusp fractures, reaches a crescendo at around the age of 60, where almost 60% of what we do is initiated by those fractures. And something tells me that probably we're doing something wrong in the early years of treating caries disease. So I think there's a reason, and I think minimal invasive dentistry has come about as a response to that realization. I think we all realize that patients themselves realize that there must be something wrong in the way we treat the early decay. Of course, it goes back to the late 19th century, where the principles of extension for prevention was initiated, and which meant that the traditional treatment of a caries lesion should be extended so that the cavity resists reoccurrence of the disease, resists reoccurrence again. And it goes back to the old Graham Wardemer, who, alongside with the principles of extension for prevention, also came up with design principles which was actually due to the mechanical properties of the then most common restorative material, that amalgam. So the principles means that the amalgam need for resistant form or retention form is supported. But what we know is that a lot of tooth substance is removed, jeopardizing the integrity of the pulp, and at the same time increasing the risk of complicated tooth fractures. And we also know that these preparations and the use of amalgam as a restorative material over time will weaken the tooth structures. What has happened over the last 40 or 50 years, though, is that the use of amalgam as the prime restorative material has been replaced by bonded composite resins, which has opened new ways of treating the disease and also to replacing and minimizing the factors of problems caused by using amalgam. This, of course, will be no news to you, but I think it's worthwhile remembering from the same perspective that we look upon the caries lesion in the tooth from a perspective of two zones. The first one being the necrotic dentine, and the other one being the translucent dentine. And we're all aware of the fact that the necrotic or infected dentin is the superficial layer of the carious lesion. It's soft in its consistency. It's highly infected by bacterial penetration. In fact, this is where we find bacteria in the carious lesion. And the collagen fibers have been degraded in an irreversible way, so that there is no possibility of remineralization of the tissue in this zone, which means that this part of the lesion has to be removed. The affected dentin, the translucent zone of the lesion, then has a different consistency. It's hard and it's leathery. There is very little or no bacterial penetration at all in the zone. It's partially demineralized, meaning that the collagen fibers are mostly intact in the city, which is extremely important because that means that there is an ability to remineralization of the tissue. And therefore, it can be preserved, or it should be preserved from that perspective. And this is, of course, has initiated the whole concept of minimally invasive dentistry. This realization of the fact of the carious lesion, as well as the use of adhesives, means that we have the possibilities of a more conservative and tooth structure saving approach than was in the past. So these illustrations just show that compared to the conventional preparation, there is the possibility of a minimum intervention preparation that actually just removes the part of the tooth substance that is actually decayed. But we also know, and as Farsila mentioned, what happens, even though we have this knowledge, especially when we leave dental school, is forgotten, because drilling is an effective, fast, established, and familiar way to remove a carious lesion. So why should we go for something else? And the reason, of course, is even if though we apply the rules of minimal invasive preparation, there's always healthy tooth substance removed in the bottom. So even though it's less with the minimal invasive procedures, there's still a lot of healthy substance that is removed. What has happened over the last few years, though, is that at the International Caries Consensus Collaboration meeting that was held in Leuven in Belgium in 2015, and then they published their results later on, a year later in May 2016, they come up with a few fairly revolutionary statements. So what they said was that when restorations indicated as a result of the carious lesion, there are some priorities that needs to be followed. And the first one being that healthy and remineralizable tissue should be preserved. We should strive for achieving a restorative seal and maintaining pulpal health, and thus maximizing restoration success. In deeper lesions in teeth with sensible vital pulps, preserving that the health of the pulp should be prioritized. In shallow or moderately deep lesions, restoration longevity becomes more important, and carious tissue removal is performed according to selective removal to firm dentine. And all these recommendations support less invasive carious lesion management, delaying entry to and slowing down the restorative circle by preserving tooth tissue and retaining teeth long time. I think this is something that we've been aware of for a very long time, but we have ignored it to a certain extent, falling back into the habits of the old way of treating these lesions. It's about time to change. Banerjee and Watson presented in the year 2000 a comparison between the different methods for restorative dental treatment. And they compared the methods of hand excavators, rotary burrs, air abrasion, Carisolv, and lasers. And they made a comparison how these different methods affected sound enamel, sound dentine, caries enamel, and caries dentine. And we're all aware of the fact, of course, that rotary burrs have a superb effect on both removing sound enamel, sound dentine, caries enamel, and caries dentine. The only difference really to that effect on the caries enamel is that of Carisolv, but it has the advantage of not affecting the sound enamel or the sound dentine on the caries enamel, but just maintaining the excellent effect on the caries dentine. So what they concluded was that Carisolv is a chemo-mechanical method to remove caries lesion because it's minimally invasive, it preserves tooth substance, it prevents complications in that it's not likely you will not end up into the pulp. It causes less pain, and we might come back to that in the Q&A sessions about why that is. But the less pain also reduces the need for local anesthesia. And it also, the procedure also provides a better dentin surface for bonding procedures. Carisolv is a system with two components. There's a gel, basically containing amino acids, 3 different amino acids, with some other components that make it into a gel. And it is also combined with the transparent liquid, which is sodium hypochlorite solution. And the combination of these two, the gel and the transparent liquid, ends up in a buffered hypochlorite solution. And the reason for this is that the sodium hypochlorite solution is an effective way of removing tissue, but it has to be combined with the amino acids in the gel that actually then will buffer the effect and lower the effect of sodium hypochlorite on the tissues, as well as breaking up the various protein chains in the decayed tissue. The benefits of this then, of course, is that it softens the necrotic tissue at the same time as it preserves the healthy tissue. It has effect on the necrotic tissue, but no effect at all on the healthy tissue. And whatever remains of the gel after it's been used has no effect on other, it's broken down into water and oxygen, basically. So the indication for using Carisolv is, first of all, as we have discussed, the caries lesions in the dentine. Open lesions, for example, on root surfaces. Deep lesions that are close to the pulp. Lesions in difficult situations, for example, in crown margins. Lesions in fissures before application of sealants. And cleaning cavities, which means removing the smear layer and open up the tubules. The last part of this cleaning cavities might not seem to be the most interesting one, but actually it is important, because what it does is that it removes the smear layer and it opens up the dentine tubuli, which is important for the bond between tooth and filling. So Neves et al. Presented a study where they had compared what the surface looked like in a scanning electron microscope after the various ways of removing the caries, anything from laser through carbide burrs through to Carisolv. And if you look upon the bottom line here and the far right, you will see what the surface of the dentine looks like after having been treated with Carisolv. You see the open tubules and you see the lack of the smear layer. Which means that after application of a bonding agent to these surfaces, when it comes to the burr group, the resin tags after the bonding agent has been applied is shorter compared to the Carisolv group, where the tags are much longer. And also in the burr group, the hybrid layer is not as thick as in the Carisolv group, which is of enormous importance actually to the bonding of the filling to the cavity and also to the longevity of the filling. So when then having noticed this in the electron microscopy, they went on to compare the microtensile strength between the filling and the tooth. And as you would have expected, the Carisolv came out on top of this, which almost, with a bond strength almost compared 100% to that of healthy dentine. So, if we are agreed on having established Carisolv as an excellent chemo-mechanical way of removing carious tissue, let's go into the clinical procedure. Carisolv comes delivered as a package of 2 syringes with accessories, packaged in pouches. What you do is you take the syringe and the accessories out of the pouch. First, you start by simply putting the plunger into the double syringe. You connect the mixing tip and the intraoral tip to the syringe. And now you're ready to go as soon as you've actually have covered the whole thing with a wraparound cover so that you can use it intraorally without problems. So this is all it takes to prepare for treatment. You might have noticed that it's stated that the product should be kept refrigerated. And the way we have done it in my practice is that we've kept it in the fridge overnight. We've taken it out in the morning. We have kept it in the operatory for the morning session. And for lunch, we put it back in the fridge. And we've taken it out for the afternoon session before we actually put it back into the fridge again for the overnight storage. I don't think there is any problem in the effectiveness of the product of having been kept in room temperature, but there is a difference in how the gel appears. It becomes more rinny if it's kept in room temperature. So once it comes out of the fridge, there's a better. The gel is more stable and is easier to apply. So keep it in the fridge as much as possible. Then you need your excavators. I don't think there's any difference. I think the only thing you have to remember is that this is a question of scraping, not cutting. So you should use it bluntly. You should not cut the surface so easily. It's easy with a hand excavator to remove also healthy tissue. But if you use it bluntly and scrape, not cut, I think you're on the safe side. I've used to finish the preparation of the cavity by using minimally invasive drills, either cavity prep drills or ceramic drills at low speed. It gives a good cutting performance without actually touching so much of the harder dentin, and the tactile sensation of using that is actually, it gives you a very good indication once you've got used to it to obtain a caries-free cavity. The important thing at all time is to remember to cover the lesion with Carisolv complete at every time. So I would use the excavator once I've started to use the gel to excavate the bulk of the caries dentin, and at all time, of course, not risking the pulp. At the end of the procedure, I would simply use the minimally invasive drills to make the last of the dentin. It gives you a very good tactile sensation, as I mentioned. And again, you don't risk the pulp in doing that. Removing all the necrotic dentin, of course, as I mentioned, means better adhesion of the filling, but you should always remember to maintain a good pulp health in that procedure. I said that the caries lesion should always be covered with Carisolv, which is important. Of course, never use it dry in the cavity. Once you start applying Carisolv, do it in a gentle way, because too much pressure might cause a splashing, and even though there's no harm in that, it's perceived as being uncomfortable by the patient. And you should anyway always have inform the patient beforehand that there will be, because of the chlorine content, a smell like in a swimming pool, for example. If you inform them about that, normally there's no problem at all. They will only feel comfortable during the use of the bariatric. So let's go into the clinical slides. An open access primary caries lesion. I'm sorry that there is a turbine where I never use a turbine for these preparations. I always use a high torque micromotor instead, with either row spur or a diamond, just to prepare access, so that I feel I can control the cavity, and also, of course, to prepare the enamel surface, remove any caries in the enamel. And prepare it for post adhesion in terms of the later restorative procedures. So then here you will see the Carisolv being applied. You will see it appear reddish in these slides, but that's simply because to make it appear more prominent or more visible on the slide. So in real life, it's actually a completely clear and translucent gel. The first time you apply the gel to the cavity, you have to wait 30 seconds so that it can start action and that the caries tissue will be softened. So no hurries. I know 30 seconds might seem as a long time to wait, but have your assistant simply time it for you, and you can have a conversation with the patients in the meantime. Then you start removing the caries tissue with your excavator, and do that until the softened decay has been removed. And then once it's removed, you can sort of repeat, you can apply more gel. And now you don't have to wait the 30 seconds. You can start using the excavator straight away. And again, I can't be stated often enough, make sure that the cavity is always completely covered with Carisolv gel when you start working on it. And you keep on working. It might seem as a long time, but it's a fairly straightforward and quick procedure, until you are sure that the cavity is free from any caries tissue. You see this start to emerge, this sort of frosty appearance. Once you've checked it with a reasonably blunt probe, you're fairly sure that you can continue, and then you start your restorative procedure according to the normal routines. That is. So as you will see, it's a fairly straightforward. You take it step by step. It might seem a bit time-consuming, but it's fairly quick procedure actually. Another cavity of the same caliber in an adult with a fairly big cavity on the occlusal surface can be removed in the same way, treated, and again you'll see this frosty appearance of the clean surface. And this is the surface we're striving for. It does not always appear that frosty as it does in those slides, but it's what we're aiming for. And this is what we know is a very good surface for the restorative procedure and creating a good bond between the filling and the tooth. And the gingival margin, quite often in a bit elderly patients, the same thing. You apply the gel, you use your excavators, in this case as quick and as fast as your drill procedure will be, and you replace it with a composite filling in the normal fashion. Nothing special. A somewhat bigger cavity. The gel is applied, waiting 30 seconds, and then step by step scraping away the caries lesion out of it until you're fairly sure. And I think you will agree with me that the combination of this sort of step-by-step procedure, scraping away with an excavator, allows you better control of where you are and makes the risk of an invasion into the pulp less likely in the process. You have better control in doing this, and yes, you will see here the enamel has been prepared just for a good adhesion to the enamel as well. I mentioned this sort of tricky situation. To me, this is a complicated situation. This is a bridge where there's been secondary caries underneath one of the abutments. And normally this to me is a very difficult situation to remove the caries and be sure how much has been removed and not undermining the reconstruction too much. But these are situations where using the Carisolv gel and scraping it away with an excavator gives excellent control, actually. Another restorative situation is when there's been post lost, perhaps due, if not due to some caries. At least there is usually some caries in the canal, and this is an excellent way of removing that caries by applying the gel and removing it with an excavator or with some other instruments, and you can sort of produce a new post, and in this case a zirconia crown, prolonging the life of the tooth itself. I think we should always strive for maintaining the natural tooth as long as possible, even though I'm very much in favor of using implants in situations like this as part of a minimal invasive treatment philosophy. But if the tooth root is possible to maintain, I think this is an excellent way of doing that. More example of these cervical cavities, not uncommon in older patients, and the same rules apply. You apply the gel. In this case, the gel is applied with the help of the excavator to the surface, left for 30 seconds again to work, and then the tissue is manipulated with the help of the excavator. And then repeated with more application of more gel until you reach a stage where all of the decay has been removed, and you have these two cavities with this nice frosty appearance ready for your restorative procedure. I know the question of how long it takes compared to traditional drilling. I think I've shown you a few examples of where it's actually is not long. It doesn't take more time than the traditional drilling procedures. In some cases, that is of course not true. It takes slightly longer than traditional drilling. At the same time, it minimizes the risk for complications in terms of the pulp or mechanical complications. And it certainly is more comfortable for the patient. Any patient with any anxiety experience this to be much more gentle than using a turbine. And because of the less less sensitivity in using chemo-mechanical procedures, the risk, you do not really need as much local anesthetics as in the traditional way of creating a cavity. And to me, when you talk about time, you also have to take into account the time required to comfort uncomfortable patients, and also perhaps the need to reschedule the patient and the cost of a patient turnaround in the operatory. I think there's another factor of time that needs to be taken into account. And to me, also going when the patient perceives this as a different kind of treatment, that usually pays off as well. And Forcilla needed, related to the reducing the need for aerosol generating procedures. It is of course true that if there is a filling or tooth substance in the way of getting access to the cavity or to the lesion itself, there are a number of situations, of course, where we can't refrain from using a turbine to get access to the cavity. But in many cases, a low-speed, high-torque electrical micromotor with a rose head burrs or a fine diamond is sufficient to gain access to these cavities and to trim the enamel borders. And also in situations where you have needed to use the turbine to actually get access, also the shifting to a low-speed motor is actually perceived as much more convenient from the patient's perspective. And you can sort of use the blunt excavator and the minimal invasive burrs to ensure a decay-free cavity, which is also a very perceived as a very gentle treatment. And the remaining debris in the cavity is easily removed by simply soaking a cotton pellet in saline and cleaning out the procedure. So it's quite easy to, just by sheer vision of the cavity, have control of the cavity being cleaned. So I think that it fits very well into now the need for reducing aerosol generating procedures. And if you take into account the things we've discussed with minimal invasive procedures in general, and the need to reduce the risk for later complication in life because of extensive preparation and removal of healthy tissue, I think that there's a good argument for using chemo-mechanical excavations. I just like to refer a number of some of these slides you will have seen before. I just want to highlight some of the clinical trials that I think that Carisolv is one of the most extensively researched procedure and method in clinical dentistry. Basically, there are several hundreds of papers written ever since the late or mid-90s on this subject. Let me refer to a number which is in support of what I've been claiming here. The first one being by Neves and Van Meerbeek from Belgium, where they've combined and saw and made a comparison between how effective methods are in removing carious dentist and at the same time preserving sound tissue. And what they call the clinical caries removal effectiveness and minimal invasive potential. They were striving sort of for aiming for the best. And you see to the left a number of methods that are under preparing and therefore leaving some caries tissue behind, which of course means complications in the future. And on the right, you see the prepared with the carbide burr and laser system, while the best CRE and MIP are found in the middle, and the best one being Carisolv in combination with a metal excavator. So I think there's a good rationale behind using Carisolv for removing caries dentin at the same time as preserving sound tissue. The other one being the one I refer to as the study. This is a study from the Journal of Conservative Dentistry back in 2009, with this comparison between actually how the surface appeared after using the various methods. And here the comparison between the Burr group and the Carisolv group in terms of removing the smear layer and opening up the tubules. And after the application of the bonding agent, the shorter tags in the Burr group and the longer tags and the thicker hybrid layer in the Carisolv group. We've seen this from another study of Neves, where the same effect on the dentine surface was compared by Neves and al, and where they compare then the resulting bond strength to the restorative material after having used these different methods, where Carisolv came out on top. And there's a specific study on root caries in vivo, and by Führer and Lindström from the University of Gothenburg, where they have compared various ways of removing caries, and also taking the time factor into consideration, where they have considered that in these complicated lesions, actually Carisolv is as fast or does not take longer time than the traditional way of treatment time in using burrs. I think to most colleagues, the deep lesions have been a road in for using chemo-mechanical preparation and excavation. I think this is a situation where you certainly don't want to risk getting into the pulp unless necessary. And as part of a strategy of selective removal or even stepwise removal of the caries tissue is this. And this is another study by Führer and Lindström, where they have compared this or see how effective it was. And the other aspect, besides the clinical efficiency that they measured, was actually how patients refer to how patients preferred the treatment, and there was no doubt in the patient's mind that this was a much more gentle procedure than using the traditional drill. In terms of dentistry in children, I think this is another aspect of where Carisolv and chemo-mechanical removal of caries tissue should be more considered. Children, I think, are more susceptible to being disturbed by the fact of the sound of the turbine or the amounts of water used when using this. And another aspect of treatment in children is that if you need to remove the debris from the fissure before sealing with composite resin, this is much more effective than using a bristled brush or any other method. So by this study by Yamada et al. From 2008, this was quite obvious. And their conclusion by Buhari and another of clinical evaluation of caries removal in primary teeth, and they combined conventional chemo-mechanical removal and laser technique. They concluded that the Carisolv treatment was the minimally invasive method that was less painful painful compared to traditional methods. And their conclusion was that it should be used more in treating children. Right. I think that's time. Farzila, back to you.
Thank you, Stefan. Brilliant presentation. I think you raised some really great points and quoted some brilliant papers as well. I'll certainly be using some of those papers when I'm teaching. So thank you for that informative presentation. During the presentation, we've actually had a few questions come in, which is brilliant. So thank you to the audience. I'm going to go through them now and hopefully we can get some answers for you. So one of the questions that we had, first questions was, do you need to wash and dry between the applications?
No.
No.
Once you have scraped out as much after the first application of the gel, you simply continue by adding more gel, and you continue scraping off, adding more gel until you're confident that you have removed all the caries tissue from it. So there's no need to do any washing in between.
Excellent. Great. And there is another question which has come in saying, can you use a caries indicator solution with Carisolv?
Sure. If you want to check with an indicator after you've actually completed your procedure, yes, of course you can, in the same way as you would if using a drill, standard drilling procedure. My experience, though, is that once you get used to using Carisolv and hand excavating out, using a not too sharp, or I wouldn't say blunt, probe, that would be, in my mind, sufficient to determine that the cavity is free from caries. The thing that I experienced myself using it was opening up less and less to gain access to the cavity. What you have to, of course, as in all these kind of therapies, you have to be aware of the fact that caries is the border between the enamel and the dentin surface. Of course, you need to be able, you need to check that carefully by doing it. But in the same instance, I think, in my mind, a probe is sufficient in doing that.
Great, thank you. We have another question which says, can it be used near the gingival margin? Will it damage the gingiva if it comes into contact?
No, I didn't. There are a number of studies that have looked into the effect that Carisolv, if it actually ends up on the gingival surface or any other of the oral tissues, or even on exposed pulp tissue. There is no effect at all on it. People do not even have any sensation if it's spilled there. As I said, the only time I experience that people, if I'm not careful enough, but actually some of the material is splashed into the throat of the patient, there is a sensation of course, of this not so very comfortable chlorine effect, but there is no biological effect on the oral tissues at all.
Thank you. Another question is, how many Carisolv applications are needed for a small carious lesion? I mean, I guess it depends on the size of the lesion, but I'll let you answer that.
But I would say that in a small lesion, I would say 2 or 3. And then you have to remember, and simply there, the reason I would add more gel is simply because I would not risk it being sort of running dry. So I would put on the first application, wait for the 30 seconds, then scrape, and as soon as I suspect that it's not caries-free or that it's dry, I would add more gel. But 2, at the most 3 applications would be sufficient.
Thank you. Another good question is there any post-operative sensitivity?
No, I think, and I haven't got a sort of scientific answer to that, but I think it's a question of, we're using materials that are at ambient temperature. So instead of spraying with cold water and air and creating that kind of sensation, we are more gentle from that aspect. And even though I suspect there might be a question relating to the open tubules and application of the bonding agent, I've never experienced any sensitization or sensitivity after that for that reason, no.
Thank you, Stefan. Another question we have is, do you need to use rubber dam?
I would not say you need to use rubber dam as far as the excavation procedure is done. I would do it if it's a very, the problem with the rubber dam to me is that you only need it really in complicated situations in terms of excavation. You might need it, of course, if you, or maybe you should use it for the restorative procedure, but there's no need for the chemo-mechanical excavations to use a rubber dam.
Great. And does it need washing before etching?
No. I think I said that after you finish after you sort of are happy that the cavity is free from Caries tissue, I soak a cotton pellet in saline and wash it until I'm confident that I've removed all the debris from the cavity.
Thank you, Stefan. Next question is, we are now advised to clear the margins but leave soft caries in deep lesions close to the pulp. How do we manage this using this product, please?
I would, for the same as with drilling, but though I would say it's easier from a clinical point of view actually than drilling. You would of course do that by either leaving the soft tissue, and if you're happy about doing that, you simply do that. You scrape away as much as you dare, and then you clean the surface with saline, with cotton pellet and saline, and then you continue your procedure. Maybe I'm old enough or conservative enough to still go for securing the longevity of the restorative procedure by doing a stepwise excavation instead. But I would not contradict. I'm sure there are a number of professors in the UK who would advocate leaving soft dentine, soft caries dentine at the bottom of the surface. I don't see any problems with that. I believe you have a better restorative long time success if you actually remove all the caries tissue.
Thank you. And then we've got a really good question here, which someone has said, is Carisolv a cost-effective product to use? And I guess I can give my view initially. I would say yes. Right now, especially given the amount of PPE, fallow period, etc., that an AGP is likely to cost you, if you can do a procedure and you don't have to use an aerosol generating procedure, you can just use hand excavators and not have to spend on the PPE and waste an hour fallow period, etc. You can definitely get more throughput of patients, which can make it more cost effective. From that point of view, I think beyond the pandemic, it's also cost effective in my view, because there are so many advantages that Stefan has gone through. Sometimes you don't need to use a local anesthetic. You're going to gain the confidence of patients because it's less invasive. Also from the patient point of view, if you are actually using this and then preserving tooth structure and tooth tissue, if you think about the long-term implications for your patient, by preserving their tooth tissue and doing less damage to their teeth, hopefully they'll end up needing less fillings, less crowns, less invasive treatment. So from that point of view, you're actually helping them as well. So in my view, that's what I would say. Stefan, you can probably add to that.
I would agree completely. And I think after starting using it, I must say I started using it in fairly young adults who presented themselves having been away from their parents and the parental control and spent money more on beer than on dental hygiene. They came up with cavities that I wanted to ensure I didn't run into problems from a pulpal point of view. Once having started to do that and expanding the use of Carisolv in my practice, both young and not least older patients who had experienced the consequences of major restorative treatment and caries excavations in the past, were only grateful for trying to maintain as much of their healthy tooth substance as possible. I think you probably all have experienced that patients are sort of fed up with having their teeth destroyed, as they would claim, and would be very beneficial very positive to using a less invasive procedure.
Thank you. Someone else has said, you mentioned that it takes a slightly longer time. How does this method work for children in terms of time?
I think that I know that some specialists in pediatric dentistry were concerned about that because they have experienced the problem with having young children, especially. But actually, the ones I have very little experience from treating children myself. But those I know who are doing this on a regular basis do not seem to have problems. The wait for the first application is 30 seconds, and with a good assistant or good, being able to distract the child, I don't think there's much problem. I think most of them experience rather the opposite, that being able to refrain from local anesthetics and not having the sound of the turbine or the splash of the water and all the rest of it actually makes it easier to treat these young children. But again, not my personal experience, but reports from colleagues.
Thank you, Stefan. Another question, actually, this is a question from me, really. I was just wondering about your preferences of using a self-etching technique versus a etch and rinse technique. Does one work better than the other? Is the bond strength affected in any way by using one over the other, or does it not matter which adhesive you decide to use when you're doing a composite?
I would, when I have control of the surface, the dentine surface of the cavity, and knowing the result from Farmerbeck group about how actually the improved retention of the bonding procedure on that dentin, I never, in those instances, I never do a total edge. I always do a selective edge of the animal and leave the dentine surface without any etching gel. Was that your question, or?
Yeah.
Okay.
Thank you. Great. Okay, so I think it doesn't look like we have any more questions, which is good timing wise. I think we have covered all of the questions that have been asked. However, if you do think of any further questions between now and when you fill in the evaluation form that we'll be sending you, please feel free to email in any questions that you have to training@ddgroup.com, and we will endeavour to answer any questions that you have. The product is available exclusively at DD. It's a really great product, and I definitely recommend that you try it. And we have Stefan has kindly produced a video which shows you step by step how to use the product. And there is also an FAQs sheet which is available to talk about the product and how it can be used effectively. So if you need access to this, you can find that all on our website on the product page for Carisolv. And we will be sending you an evaluation link for the form within the next 24 hours. And please fill in this form if you can. Any feedback that you give to us is always welcome, and we are constantly trying to improve. So please let us know what you thought of today's session, and if there's anything in particular you would like to see in future upcoming webinars. If you fill in the evaluation form, it will also enable you to get your CPD certificate for your 1 hour free CPD. So finally, all I have to do is thank Stefan for a great presentation and a really informative question and answer session. Thank you to our audience for raising the questions and for listening in this evening. We hope you enjoyed it and found it helpful. And if you've got any questions, please contact us directly or contact one of the sales team. Thank you and good evening.
Thank you very much and good evening.